Hello everyone. Sorry for the delay. I just come home from a very long day. Today we are going to continue our journey with physiology. So we will discuss the physiology. We'll start with the physiology of lacrimal system, and this is one of the very important topics in the physiology. So let's say, for example, that almost every exam has a question in the lacrimal system physiology. So our lecture will be about the what is the tear film, what are the functions of the tear film, what are the constituents of the tear film, and what is the function of each layer, and how to test for each layer. This will be the broad lines of our lecture today. So what is the tear film? Let's just make the pointer like a pen. Okay. So we know that the tear film is this fluid layer that will overlie the corneal and the conjunctival epithelium, and it's important for the nutrition for each of them, and it is produced by some contents within the conjunctival epithelium, as we will say later. The thickness of the tear film is about 40 microns, and the numbers here in the tear film is important or are important. So you should know what is the thickness of each layer and what is the thickness of the total of the tear film. The volume of the tear covering the ocular surface will be ranging from 2.7 to 7 microliter. So if I told you that this will be the amount of tear film that is present in the conjunctival sac. So if I told you that the size of the one drop from an eye drop is about 500 microns. So if you put an eye drop within the eye, it is normally to some of this eye drop to spill over the cheek or to spill over from the eye, because not all the eye drop will be accommodated by the conjunctival sac. Let's review some basic anatomical data about the lacrimal apparatus. So we know from anatomy that the lacrimal fluid is secreted by the lacrimal gland, or the main secretion comes from the lacrimal gland. Then from this lacrimal gland, the lacrimal fluid passes through the lacrimal ducts into the orbital part and the palpebral part, so that it will open into the conjunctival sac at the superior fornix at the lateral part. So then the tear film will cover and coat the surface of the cornea, and then as it is present on the lower lid, it will collect mainly at the inferior punctum, and some of it, about 30%, in the superior punctum. Then from here, the lacrimal system with the tear film will be drained out from the eye through the drainage system. The drainage system is made from the two puncti, the upper and lower, then the superior and the inferior canaliculus, then the common canaliculus, then the lacrimal sac, then the nasolacrimal duct, then it will open into the nasal cavity. So this is just a rapid review about the anatomy of the lacrimal system. So let's start with the functions of the tear film. What are the functions of the tear film? Some of these functions you can guess, and some of them we have mentioned sporadically as we go through our course. So it is more or less logical information. So we know that it is a lubricating fluid that will cover the corneal interface or the lid corneal interface. So without this lubricating fluid, there will be a hard friction between the cornea and the lid, making the cornea making the movement of the eyelid painful over the surface of the cornea. So it will be like a lubricating fluid between both surfaces. It also has a protective function over the cornea. It will, as we will see later on, we will see how much the contents of the tear film as it contains a large amount of antimicrobials that will have a function to protect any organism that may invade the cornea. And also it has an optical function, as they will form an optical surface. So there will be an air corneal interface. So this cornea is covered by the tear film. So the tear film air interface will form an optical surface that will aid in the refraction of light rays. Precorneal tears are very rich in the antibacterial compounds that will protect the eye from any invading microorganisms like lysozymes, like immunoglobulins, and others. Also, the perfusion fluid will wash out the debris from the corneal surface, and you can consider it like the windshield wiper. So, as the windshield will wipe out any debris that are falling on the glasses or the glass of the car. So, the tear film act on the same function. So, it will wipe away any debris that will maybe fall on the corneal surface, so that it will not damage the eye. Also, we can consider it as a reservoir for topical antibiotics and topical drugs. So if we are putting an eye drop, and this eye drop needs a medium to be instilled into it, so that the tear film will serve as this function. It will act as a temporary depository or a reservoir for the topical eye drops in order to be effective over the surface of the eye. Also, one of the functions that we said before, that it will be the main oxygen supply to the corneal epithelium. We said that the cornea needs some nutrition, and the nutrition mainly come from oxygen and glucose. So the main source of oxygen come from the air, and the oxygen diffused in the precorneal tear film, while the glucose is mainly coming from the aqueous behind the cornea. Going further into the structure of the tear film is not as simple as it looks, but it consists from 3 layers. The most inner layer that is in conjunction or in contact with the cornea, it is called the mucin layer or the mucinous layer. Then this is followed by another layer that will make most of the thickness of tear film, which is called the aqueous layer or the watery layer. And finally, the final layer or the last layer or the most outer layer that is in relation to the air will be the lipid layer. If we have a section in the tear film, so we can find that this is a corneal epithelial cell, then this is the mucinous layer. Then there is aqueous mixed with the soluble mucin, and this is lipid. So just to make a hint now that the mucin is soluble or the aqueous layer is soluble within the mucin. So the mucin is not only limited to the inner part of the tear film, but the aqueous itself will be mixed with the mucin along large thickness. So let's start with each layer. Each layer, we need to know what is this layer, what is its location, where does it come from, and what is its thickness, what is the constituents of this layer, and what is the function of this layer. So starting by the lipid layer, so the lipid, as it apparent from its name, it is an oily layer. This oily layer present at the outermost surface of the tear film with its thickness of about 0.1 micron. So knowing that the tear film is about 4 to 40 microns, so it has a very, very minimal thickness. As you can see here, it is very minimal thickness in regard to the thickness of the tear film. The lipid layer comes mainly from the meibomian glands, so this will be the main source that will secrete lipids, as we said before in the anatomy, and the Zeiss glands also will secrete sebaceous secretions, which will share in the formation of the lipid layer, but to a little extent. Here we come to the composition, and the composition is asked frequently in the MCQ. So I know that it doesn't sound very nice to remember figures, but unfortunately these are asked in the exam. But I will try to focus on the important figures and the important constituents that are frequently asked. So what are the contents of lipid layer? So basically it's formed of different types of lipids. The most important and the most numerous lipids are cholesterol esters and waxes. So this is asked in the MCQ. What are the most common contents that will make up the lipid layer of the tear film will be the cholesterol esters and waxes. Other contents in a smaller amounts are the triglycerol, the cholesterol, the fatty acids, the esters, and some unidentified fats. So here we come to the functions of the lipid layer, and this is again a question that has repeated before. What will be the function of the tear film? Is it important, or the oily layer or the lipid layer? Is it important that this lipid layer will be at the outermost surface? Yes, it has this configuration or this arrangement is not by coincidence, but it has a purpose and it is meaningful, as it will form a film over the aqueous layer so that it will prevent rapid evaporization of the tears. So since this lipid layer will be the outermost part, this will be in relation to air, and it will coat the aqueous layer, preventing the rapid evaporization of the aqueous layer, so that it will guard against this rapid tear loss. Also, it has another function to prevent the spillover of tears over the lid margin. Since it will be the outermost part, and as it is secreted from the meibomian gland, so it will be secreted by the lid margin. So it will be adherent to the eyelid skin. Again, since it is adherent to the skin, it will keep the aqueous layer at its level. It will prevent that this aqueous from spilling over the cheek, and it will keep it in its place. Also, if we don't have this lipid layer and we try to close our eyelids, this will be a rapid loss of the tear film. So it will be the tear film will flow over our cheek because the lipid layer will form a watertight seal when the lids are closed. So this is like another explanation of number 3. It will make the lids close tightly so that no spillage of tears come from the eye. Also, it provides a clear optical medium, so it has an optical function. So these are the main functions of the lipid layer. This is very important to know, that it prevents the evaporization of tears and prevent the spillage of tears. These are the main functions. So we need to know how to test. There is a device called the interferometry. The interferometry is able to detect each layer thickness. So if the layer thickness is minimized or decreased, we know that there is a deficiency in the secretion of this layer. Also, we can do transillumination. So by just a transillumination of meibomian glands, we can detect if there is any meibomian gland dropout. So the meibomian glands appears as yellowish streaks, vertical streaks at the undersurface of the eyelid and the palpebral conjunctiva. So if they are not present, so we may suspect that there is a meibomian gland dropout. Also, slit lamp examination will show the tear film show meniscus floaters. So what are these? The meniscus floaters. You can see floaters like here. These floaters are simply the discoamated cells with contaminated with lipid and mucin. So this is one of the signs that this patient may have a dry eye, as these cells are coming from the undersurface until they reach superficially and then could become mixed with the mucin and lipids. So this appears as a tear film instability present with these cells. Although sometimes it sounds a clinical question, but they tend to ask about what is the clinical problem that may manifest after a deficiency of each layer. So we need to know what will be the clinical manifestations of deficiency of lipid layer or aqueous layer or mucinous layer. As we said, that the lipid layer is coming mainly from the meibomian gland. So if there is a meibomian gland dysfunction, then this will affect the lipid layer. So what will be the effect? I guess you know now that the thickness of the lipid layer will be decreased, so that this will lead to rapid evaporization of the tears and leading to dryness. And also this will lead to spillage of watery layer. So the aqueous layer will spill over the cheek, and this will be the one of the strange signs that may be reported by the patient. So it will be the patient may report that he has an excessive watering, and he will be surprised that you are telling him that he has dryness. So he will ask you, how could I have dryness since I complain from severe watering? So here you need to explain that this severe watering is due to loss of lipid layer caused by meibomian gland dysfunction. Also, there is sometimes when there is obstruction of the meibomian gland ducts, this will lead to stagnation of the secretion or the lipid secretion within the meibomian glands, and this stagnation will invite secondary infection by Staph aureus or other bacteria that will produce the enzyme which is called the cholesterol esterase. This is also important. Cholesterol esterase and the fatty wax esterase will destroy or will hydrolyze the main lipids within the meibomian glands. So this will cause the froth that is clinically significant for the presence of meibomian gland dysfunction. So for sometimes we can see like a froth over the orifices of meibomian gland, or we can see that there is an oil droplet over the orifices of meibomian glands. This is a sign of meibomian gland dysfunction or meibomian gland obstruction, and this will predispose to dry eye caused by deficiency in the lipid layer. The aqueous layer will form the middle and the most thickness of the tear film, which is simply the watery layer. You will find in some books that the thickness is about 90%, and this is historical, or this is an old data, because after the advent of the specular, the confocal microscopy, so we now know that the tear film, the aqueous layer, is forming about only 60% of the tear film thickness, and the remaining will be made by the mucus layer. So the thickness is about 10 microns, and the source of the tear film will be coming from the main lacrimal gland. It's about 95% of the tear film is coming from the lacrimal gland. And also the accessory lacrimal glands of Krauss and Wolfring will share in a minimal to a minimal extent within the aqueous layer of the tear film. Here we come to the control. How does the body control the secretion of the aqueous layer? This has three main controls. The first one will be neuronal, and we have mentioned about in the anatomy. We said that the anatomical nervous system will control the secretion of the tear film, meaning that the parasympathetic system through the facial nerve will increase the tear film production, but through just a stimulation of the myoepithelial cells surrounding the acinar cells. So by just the contraction of the myoepithelial cells through the branches of facial nerve, this will lead to that the acinar cells will produce their secretions within the central duct until they reach out from the lacrimal gland. Also, the sympathetic system has the same effect, but as it will increase the tear film, but through a different mechanism, as it will alter the blood supply. So it will increase or decrease the blood supply to the lacrimal gland. That's how it can control the tear film production, or the aqueous layer of the tear film. Another effect will be the hormonal. So some hormones may have a role in the production of the aqueous layer, such as testosterone can produce the secretion of certain tear components such as immunoglobulin A, while reduction of the tear flow in women after menopause also occur. Psychological factors, so we know that when extreme happiness and extreme sadness, this can also lead to tear flow. So the psychological effect also shouldn't be overlooked. Here we come to one of the most important things in the physiology of the lacrimal system, which is the composition of the aqueous layer. We can find that since it is called the aqueous layer, it will be made mainly from water. It will be making about 98%. The other 2% will be made by electrolytes, proteins, oxygen, glucose, and vascular endothelial growth factor. Can you see the slides, or Dr. Suham has a problem with seeing the slides? Can you see the slides? Dr. Suham, I guess that you have a problem at your connection. Just hold on, I won't just the battery of the laptop will be down, so I will just bring the charger. Okay, so these are the different contents within the aqueous layer of the tear film. Let's just review what are the composition and what are the percentages of these contents. This table is present in Qurana and other physiology books, and for the first instance, you will be shocked from this table. So let me just break down what are the important data about this table and how can we memorize it in a simple way so that we can solve any question that may be asked about the chemical composition of the tears. As we just mentioned, the tears will be formed of about 98% of the tear film will be made of water, so this is like easy, and the remaining the 2% will be made of the solids like proteins and electrolytes and others. So the first thing, that is the sodium. The sodium will be the same in the tears like in the plasma, so they will be equal, no difference in the sodium. Potassium here is, they like to ask about potassium. So potassium is, the concentration of potassium is like 6 times in the tears more than the plasma. So 30 to 5, it is like 6 times. This is due to the effect of the sodium-potassium ATPase pump. The chloride will be the higher in concentration than the tears and than the plasma. So the chloride here is more again. The bicarbonate is slightly more in the tears than the plasma, and this what will make the tear film alkaline. So the tear film is alkaline because it has excess bicarbonate more than the plasma. Then the total proteins will be like about 1/10 of the plasma. So the tears have minimal proteins like about 0.6. So this will be 6 grams. So it will be 1/10. So the total proteins are less in the tears than the plasma. Then we have the glucose, which will be the second most important. So the glucose here will be of the limited amount or small amount than the plasma, as it will be consumed over and over again. So it will be consumed every now and then, and this will lead to decrease its concentration more than the plasma. So again, to summarize, the sodium will be the same in the tears and the plasma. Potassium will be 6 times more in the tears than the plasma. Chloride will be more. Bicarbonate will be more, leading to alkaline pH of the tear film. Total proteins will be less than the plasma. And the glucose will be less than the plasma, as it will be consumed very rapidly. So these are about the electrolytes. Let's now review the proteins, the protein content, and this is the one of the again the second most important slides in this lecture. So what are the proteins present in the tear film? What are their concentrations? We have bactericidal enzymes. Tear film is very rich in bactericidal enzymes like lactate dehydrogenase, like lysozymes, like lactoferrin, and the beta-lysins. These are enzymes and the products that have antimicrobial effect. They will neutralize the microbial activity. So the lysozymes, for example, will be integrated inside the microorganism, causing its lysis. Lactoferrin will bind by the will bind with iron, so that if there is an antimicrobial that is dependent on the iron, they will inhibit them from acquiring the necessary iron for their growth, leading to their death. And also we said that in the last lecture that it will neutralize the free radicals by the Fentone reaction. The beta-lysin also is a bactericidal that will act on the cell membrane of the microorganisms. So this will give you a clue about the importance of the tear film, that without the tear film, a huge amount of protection against microorganisms is lost. The second thing, or the second defense mechanism against the microorganisms within the tear film will be the immunoglobulins. In the immunoglobulins, the total immunoglobulins will be less than the plasma. And each immunoglobulin, so it was asked before in the exam that if the immunoglobulins are more in the tear film or more in the plasma, so it is more in the plasma. But sometimes they are increased in specific conditions. For example, the immunoglobulin A and the immunoglobulin G will increase in infection. Immunoglobulin E will increase in the spring catarrh. Immunoglobulin IgM and IG, I think this is IgG, are also present. So where do these immunoglobulins come from? They come mainly from the lymphoid tissue. This lymphoid tissue present in the lacrimal gland stroma or the conjunctival stroma. So again, the immunoglobulins come from the lymphoid tissue present in the lacrimal gland stroma and the conjunctival stroma. Also, one of the important proteins present in the tear film will be the epidermal growth factor, which will be responsible for growth and the maturation of the epithelial cells. So once the corneal epithelial cells are lost, under the effect of the epidermal growth factor, this will lead to mitosis and the proliferation of the epithelium, causing a closure of the defect. So this is again one of the most important healing factors. Also, oxygen is one of the important contents of the aqueous layer, as it will provide the corneal epithelium with the necessary oxygen. As we said, that the main oxygen coming to the cornea will be coming from the precorneal tear film and diffusion from the limbal capillaries. So then the oxygen pressure will be 155 millimeter mercury, but this drops to about 55 millimeter mercury, and this will lead to a relative edema as we get up in the morning, because of the relative hypoxia that the cornea was standing in during all night as the lid was closed, and this edema may increase, causing a blurring of vision with patients who have poor endothelial function, as patient with Fuchs endothelial dystrophy. If this patient is a contact lens wearer, then this will lead to even further drop of the oxygen saturation and oxygen pressure within the tear film up to 20 millimeter mercury. That's why the contact lens can cause hazardous effect over the cornea. It is due to decrease of the oxygen saturation of the tear film, leading to decrease the nutrition for the cornea or the oxygen, which will be also needed for biological functions such as the pump mechanism by the endothelium to pump out the fluid, which will be, as we said, it will have aerobic and anaerobic. So the aerobic content or aerobic component will be lost here. Also, the glucose is present in low amounts in the cornea, but it is very low, so it will not be sufficient to supply the corneal need. So the cornea will take its main need from the aqueous, not from the aqueous. But this content will be sometimes elevated in hyperglycemia, so that the patient, the tear film will have high glucose content. So to summarize, the tear film has excess water, have excess potassium, about 6 times than the plasma. It has excess antimicrobial enzymes like lactate dehydrogenase, like lysozymes, like lactoferrin, but they have low bicarbonate, protein, immunoglobulin, glucose, and ATP. So they will be consumed every now and then. But the sodium is almost equal in both sides. Okay, so what is the function of the aqueous layer? The aqueous layer will provide oxygen to supply the corneal endothelium, as we just mentioned. So this is the main oxygen supply to the cornea, and also it has a factor to wash out any debris. It was the same like the previous layer. The antimicrobial rule through the lysozymes, lactoferrin, and immunoglobulins. Healing factor through the epidermal growth factor. It will cause smoothing the irregularities of the corneal surface, so it has an optical function. And it also has an important role in the corneal detergescence, as it has an osmotic pressure. So since this is a fluid that has salts, then these salts will increase the osmotic pressure of the tear film. And since the osmotic pressure of the tear film is high, it will withdraw fluid from the cornea, causing water flux from the cornea, leading to dehydration of the cornea. So this is one of the mechanisms of the corneal dehydration or corneal detergescence. So how to test the aqueous layer? We have several tests. First of all, we can test the tear film production itself, or the aqueous layer production itself, using the Schirmer test. Or we can measure the osmolarity. So if the osmolarity is high, then this means that the aqueous layer is deficient, and vice versa. If the tear film is very diluted, then this means that there is a high or excess production of the aqueous layer. Or we can measure the tear enzymes. So since the enzymes are produced from the aqueous layer, so the rate of production will be the same of the rate of formation of the aqueous layer. So what are the clinical manifestations from deficiency of the aqueous layer? The aqueous layer deficiency can manifest in different manifestations like keratoconjunctivitis sicca, like Sjögren's syndrome, in which there is autoimmune antibodies that will attack the lacrimal gland, and another disease called familial dysautonomia. So if you present like which one of these diseases are due to the malfunction or deficiency in the aqueous layer of the tear film, you should know what are the diseases that will be affected by that will occur due to deficiency of the aqueous layer. Finally, we have the mucinous layer. So the mucinous layer is the deepest layer of the tear film. So the essence is that the mucous layer or the mucinous layer is the deepest layer. It will be at the junction between the aqueous layer and the corneal epithelium. It's the thickness was thought to be about 0.02 micron to 0.05 micron, and again this was historically. But now, after advent of the confocal microscopy, it was now found it is 30 microns. So if I told you that the tear film is about 40 microns, it is 10 microns that of pure aqueous, and about 30 microns will be about of the mucinous layer. So they are not present or not concentrated just at the tear film corneal junction, but almost the aqueous layer are dominated by this mucin. So the mucin will invade through the aqueous layer. So that is, sometimes we can call it like mucin dominant gel hydrated by aqueous fluid. We see that the mucinous layer is a mucin dominant gel, so it is a gel made of mucin that is hydrated by the aqueous layer. What will be the contents of the mucinous layer? We took a hint about the composition of the mucinous layer or the function of the mucinous layer from the corneal lecture. So let's discuss this in more details. So we said that the epithelium of the cornea shows some surface microvilli that are called the plicae or the microplicae. This microplicae will be interdigitated with the mucinous layer, which will be formed of two main contents. The first of all called the glycocalyx. These glycocalyx are a network of polysaccharides. These polysaccharides will bound to these microplicae so that it will cause tightening of the tear film to the surface of the cornea. So it will make the tear film adherent to the surface of the cornea. And these glycocalyx are made by the epithelial cells of the cornea and the conjunctiva, and this is asked in the MCQ. So again, the microplicae, that is one of the main contents of the, or one of the two layered structures of the mucinous layer, is made by the conjunctival and the corneal epithelium. The other thing is the mucus blanket. So here is the glycocalyx. You'll find that the glycocalyx is covered by a mucinous layer or what's called the mucus blanket. This mucus blanket is thick, loose layer which is produced by the conjunctival goblet cells. So here is the one of the main function of the conjunctival goblet cell, that it will produce the mucinous layer of the tear film. So if there is any damage to the goblet cells, like scarring in the conjunctiva, this will lead to damage of the goblet cells and the deficiency in the mucinous layer. Sometimes it's asked in the MCQ what's called MUC5AC. This compound is the main tear mucin. So as we know, the main tear lipids in the lipid layer, we should know what is the main tear mucin. It's called MUC5AC. So to summarize, apart from the thickness, we have this is the contents of the tear film. We have the lipid layer, the outermost part, then the aqueous layer, at which there is a mucinous layer. This mucinous layer will show some free mucus within the aqueous layer, and this mucinous layer is formed by glycocalyx, which will be interdigitated with the microvilli of the surface epithelium of the cornea and have a surface blanket, mucin blanket layer. So what is the function of the tear film? I told you a sentence in the corneal lecture, and then I told you to postpone it as we will discuss it later on. So I told you in the corneal lecture that the surface or the corneal epithelium is hydrophilic and it is not hydrophobic. And this is one of the mechanisms for corneal dehydration. So it is now, here we come to understand what is meant by hydrophilic and hydrophobic. So we can suppose that the corneal epithelium, since they have lipids, they will have high surface tension, so that if there is any water is spilled over the corneal surface epithelium, this water will make this globular shape. So you see that this is a bottle containing mercury, and the mercury has high surface tension. So once it's out of the bottle, it will make drops, and this drops has a globular surface because it have high surface tension. The same thing occurs with the corneal epithelium, and they have lipid content. So if you spread any water over the corneal epithelium, this will lead to that this water will make such drops. So This will lead to, if there is a tear film, the tear film will not spread equally over the cornea, so that there will be some dry spots leading to dry eye and other ocular surface problems. So the main function of the mucinous layer is to make the surface of the cornea from hydrophobic to hydrophilic. So this surface can be rendered from hydrophobic to hydrophilic. And if this is condition, then if any water or the tear film will spread over the surface of the cornea, nice and smooth, and will not produce any discrete droplets like this. Also, the mucinous layer will reduce the surface tension between the corneal surface and the tear film. So this will be the mechanism. The mucin will act as an intermediate compound or intermediate layer that will decrease the tension, surface tension between the corneal surface and the tear film. Also, it will prevent the surface lipids and the proteins in the aqueous layer from reaching the surface epithelium to produce dry spots. So if there is any desquamated cells or lipids or proteins present in the aqueous layer are circulating freely in the aqueous layer and they want to sink down to reach the epithelium, this mucinous layer will prevent them from to do so, and also it has a function of lubrication. So did you get now what is the function of the mucinous layer and what is the function of other layers? This is very important for the purpose of exam. So to test for the mucinous layer, if there is deficiency in the mucinous layer, this will lead to that the surface will or there is a test that will test. We will mention it in much details now, but it will basically it will just producing a drop of fluorescein and then ask the patient to stand still without blinking, and you will find that there is some black spots due to rapid evaporization of the tear film or a decrease of the tear film due to appearance of black spots due to deficiency in the mucinous layer. So clinically, what will cause deficiency in the mucinous layer? This will be caused mainly by diseases that may cause scarring of the conjunctiva. So, or it is due to absence or deficiency in the mucin in the tear film, which will be caused by some diseases like vitamin deficiency, scarring of the conjunctiva caused by autoimmune disease such as ocular cicatricial pemphigoid and the Stevens-Johnson syndrome, and alkali burns, trachoma, chemical burn. All these can cause damage to the goblet cells, leading to reduction or absence of the mucinous layer. So this will lead to rapid breakup of the tear film. Even that there is adequate volume of the aqueous layer, but the tear film will cause rapid breakup and rapid loss, so that this will lead to what's called the keratinization of the cornea. So here is the clinical syndrome of deficiency of the mucinous layer, which is called xerosis. So xerosis occurs due to deficiency in the mucinous layer, not the aqueous layer, not the lipid layer, but it is only for the mucinous layer. So here if you have a layer containing mucin, this layer containing mucin will prevent that these compounds like proteins, like solutes, like sodium, like chloride, to reach from the corneal epithelium. So this will be one of the functions of the tear film, of the mucinous layer. And this is table will summarize the lipids and the aqueous and mucin different sources and what are the primary contents and what is the primary role. So how can we, or what are the mechanisms responsible for regulation of the tear film? Well, for the mucus layer and the aqueous layer, they are secreted or they are regulated by neural reflex, as we just saw. So the aqueous layer will be regulated by the sympathetic and parasympathetic the lipid layer will be regulated by the blinking. So the blinking will cause release of the secretions of meibomian glands and its distribution over the surface of the cornea. The tear secretion is balanced by drainage and evaporization, so we should have a balance between the amount or the rate of tear film production and the rate of drainage. The drainage itself is regulated by the neural reflexes, and the evaporization depends on other factors apart from the internal regulatory mechanisms, such as the temperature, the humidity, and the wind speed. So if they increase, there will be much more loss of the tear film. That's why we advise patients who have dry eye not to stand in front of air conditioner or in a humid weather. Let's now talk about the dynamics of the tear film. How can the tear film is produced, and how does it will be, or how will it be removed from the eye? So first of all, the tear film will form a marginal tear strip over the lower eyelid margin. So here is the tear film. Once the eye will be contracted, this will create a negative pressure. This negative pressure will push the tear film into the puncti, to the canaliculi, and into the nasolacrimal sac. Then, once the eye open, then this will lead to relaxation of the orbicularis oculi muscle, and this will create a positive pressure. This positive pressure will close the puncti and force the tear film to pass from the nasolacrimal sac to the nasolacrimal duct. Then tear production will occur, or tear secretions will form again from the lacrimal gland, and the circle goes on. So this is called the dynamics or the lacrimal pump mechanism. We have two functions. When the lid closes, this will lead to muscle contraction, causing negative pressure on the lacrimal sac, leading to suction of the tears to the lacrimal sac. So it will help the tear drainage. But when the eye opens, this will create a positive pressure due to muscle relaxation, causing closure of the puncti and the pushing of the tear film into the nasolacrimal duct. Finally, we will come to the lacrimal functions test. Lacrimal function test, we mean by lacrimal function test, how can we test for the secretion of each layer of the tear film, and how can we test for drainage if the patient is complaining from watering of the eye? This can be due to either hypersecretion or due to a problem or deficiency in drainage. So how can we test for each of them? Let's start by tests for secretion. So we said about the lipid part or the lipid layer, we can detect it by interferometry or by transillumination of the lids to see if there is any loss of the meibomian glands, or if there is any disquamated cells present are floating into the aqueous layer of the tear film. So here you can see what is meant by transillumination. You can see that this area lack the striations of the tear of the meibomian glands. So this means that there is a meibomian gland the loss here. For the aqueous layer, this can be done by several methods, either clinically or by investigations. So clinically, we can examine that what's called the marginal tear strip. The marginal tear strip is simply, it's about 0.5 or 1 millimeter thick tear film layer over the inferior lid margin. If it is deficient or if it is absent, then we can suspect that this patient may have deficiency in the aqueous layer. Another test important for examination or testing for deficiency in the aqueous layer is called the Schirmer test. In the Schirmer test, we apply a specific paper called the Whitman 41. This paper has specific dimensions, like the width is about 5 millimeters, while the length is about 35 millimeters. and we apply it into the lower lid at the junction between the outer 1/3 and the inner 2/3, so that it will be folded and will be inserted into the eye. And measuring the aqueous layer will be dependent on the amount of wetting of this special paper. And this amount of wetting can be due to either basic tear secretion or reflex tear secretion. Reflex meaning that if there is a foreign body sensation, or if we put this tear of if this strip in the cornea or in the conjunctival sac without putting as a local anesthetic or a surface anesthetic, this will lead to irritation of the cornea. So it will lead to foreign body sensation, so it will lead to reflex lacrimation. So in this condition, it will measure both the reflex lacrimation and the basic lacrimation, and this is called the Schirmer 2. But if we put a local anesthetic or surface anesthetic, then when we put this Schirmer, when we put the Whitman 41 paper, then it will measure only the basic secretion because there will be no irritation to the cornea, and in this condition it's called Schirmer 1. And it is logic that the Schirmer 2 test will be, or the value of the Schirmer 2 test will be higher than the Schirmer 1. So here we put the Whitman 41 paper, and it will be folded at 5 millimeters, so that it is from 0 to 5 millimeters. They will be bent inside the conjunctival sac, and then the patient will close his eyes gently, and then we leave this paper for 5 minutes. So the secret number here is number 5. The width is 5. It will be left for 5 minutes. Then the result, if it is less than 5 or less than 6, then it is abnormal. But this is with anesthesia, so it will be the Schirmer 1. But if it is less than double 5, which is 10, in case of Schirmer 2, then this is considered again abnormal. So again, the result of this test is if it is the wetting of the paper is less than 6 or less than 5, then this is considered abnormal in case of Schirmer type 1, in which we put anesthetic. But if we don't put anesthetic, so we test both the reflex and basic secretion. Then if it is more than 10, or sorry, it is less than 10, then this is considered abnormal test results. So this will demonstrate the deficiency in the or the excess aqueous layer. Sorry, it will demonstrate the deficiency in the aqueous layer. Then we can test the amount of dilution, meaning that since we can put a fluorescein, this test is called fluorescein dilution test. So we test the rate of dilution of a known volume and concentration of fluorescein that is instilled into the conjunctival sac. Then by a device called fluorophotometry, we can measure the rate of dilution. So the rate of dilution of fluorescein will reflect the rate of formation of the aqueous layer. Also, another important test will be the tear osmolarity. As I told you, that the tear film has an osmotic pressure formed by the salt contents within the tear film. It is about 300 milliosmol per liter, and if there is number increased, mean that the tear film there is a dehydration or the aqueous layer is deficient. But if this number will decrease, or if it is decreased, meaning that the tear film is diluted and there is excess amount of aqueous layer. And also, if there is a high vaporization, so the tear film will be concentrated, leading to a rise in the osmolarity. We can also measure the aqueous layer amount indirectly by measuring the enzymes that are produced within the aqueous layer. So they can be indicator for lacrimal gland function, such as the lysozyme. Lysozyme can be determined by different measures like spectrophotometric method, immunological method, lysis method on agar plates, different methods. You just need to know their names only. Then we have some tests for the mucus portion. The first one will be the breakup testine. So if there is any deficiency in the mucin layer, this will result in a high incidence of breakup of the tear film layer. So this can be tested by putting fluorescein eye drop within the eye. Then the patient will blink several times in order to spread the fluorescein drop over the surface of the cornea. Then ask the patient to stand still and remain staring without blinking for a few seconds, and then will be examined by the blue filter. If there is appearance of black spots, the black spots will appear sooner or later. This is due to break of the tear film. But this black spots shouldn't appear before 10 seconds. So if they appear after 10 seconds, then this is considered normal. But if they appear before 10 seconds, then this is considered abnormal, and this is a patient who has a deficiency in the mucus layer. Here you can see that this patient has black spots that appears in few seconds after the patient remains staring. So this means that the patient has tear film instability due to deficiency of the mucus layer. Other methods for examination of the mucus layers, we can examine the goblet cell count using what's called impression cytology. We can stain the conjunctiva for any scarring or any lesions by rose bengal stain and lissamine green stain, and we can do the tear. Okay, so we will continue from the interruption point. Let's start the final part of this lecture, which will be the test for drainage. Okay, so the first test is a crude test or a general test to know if there is any lesion or any obstruction of the outflow, but it will not localize where is the obstruction. This will be called the fluorescein disappearance test. In the fluorescein disappearance test, basically what we do is we put up a fluorescein inside the eye and then ask the patient to blink several times. Then by examination using the blue filter, we examine the presence of any remnant of tear of fluorescein stained tear film. It should disappear after 3 minutes, meaning that if you put the patient at the back of your clinic and after 3 to 5 minutes you examine him again, you should find that all of this fluorescein stained tear film will go away. But if this is not the case, meaning that this will mean that there is a problem with the outflow, or there is a problem with the drainage of the tear film. So if there is any retention of the tear film, this means that there is a problem with the tear film drainage. As you can see here, you can see what's called increased marginal tear strip. So the marginal tear strip should be about 1 millimeter, but as you can see here, its thickness increased up to maybe 3 or 4 millimeters. So this means that this patient may have obstruction of the outflow. The second step is to do what's called probing and irrigation. This is like more clinical data or clinical information, but for some reason they are mentioned in the physiology books and they are sometimes asked in the exams. So it will not harm to know about them. So the second step after doing the fluorescein light disappearance test is we do probing and irrigation. By probing, we mean we put a dilator. This dilator will be by scrolling movement we can dilate the inferior punctum in order to introduce this cannula or what's called the probe. This probe will be advanced through the inferior punctum, inferior canaliculus, and the common canaliculus until it enters the lacrimal sac. This can be done by topical anesthesia, so dilatation of the punctum, then passing the lacrimal probe through the inferior punctum and the inferior canaliculus toward the common canaliculus. Then the result will be either we pass through, we will find what's called soft stop or hard stop. What does it mean to have a hard stop or soft stop? By hard stop, we mean that the probe was advanced through the inferior canaliculus, then the common canaliculus, then it entered the lacrimal sac and it hit the nasal bone. So we feel the hardness of the nasal bone. This is what's called the hard stop. On the other hand, if we introduced the probe within the inferior canaliculus and we find a resistance, this resistance is like soft tissue obstruction, and we push this resistance and we push it against the bone, so this is called a soft stop. So in case of the hard stop, the probe actually entered within the nasolacrimal sac. But in case of soft stop, the probe didn't enter the nasolacrimal sac. So what happens next? In order to localize where is the lesion or where is the obstruction, the third step is to do irrigation. So the lacrimal irrigation or syringing is by putting a cannula inserted with a syringe filled with the saline, then we inject it, and then we can find that and we observe the movement of the flow of the fluid injected through the inferior canaliculus. Meaning that in case of soft stop, if we have a soft stop, and then this means that the sac will not be distended. As we irrigate with the saline, the sac will not distended because the probe didn't enter within the lacrimal sac. So what happens if we inject saline? We have one of two options. Either it will come from the upper canaliculus, and then this means that there is a obstruction at the level of the common canaliculus. But if it comes from the same side where it enters, then this means that there is an obstruction in the inferior canaliculus. Again, if the saline comes from the lower punctum, this means that there is a lower canalicular obstruction. But if it comes from the upper punctum, then this means that there is a common canalicular obstruction. So here is the first possibility, that we have a soft stop. The second possibility is that we have a hard stop. The hard stop means that the probe has entered the lacrimal sac and it hit the lacrimal bone. So to know where is the obstruction, we just place a finger over the lacrimal sac. Why? Because we want to inject and force the fluid to the nasolacrimal duct. So place a finger on the lacrimal fossa and irrigate. Then we have two options. The first option is that no saline is retrieved from the nose. So it didn't pass through the nose or it didn't reach the nose, and this is mean that there is a complete nasolacrimal duct obstruction. As in this condition, the sac will distend and the reflux may occur from the upper punctum, but there is no saline coming from the nose. So that the nasolacrimal obstruction, total obstruction. The other option that the saline passed to the nose. So we have three options here. Either there is a partial obstruction or stenosis, or there is hypersecretion of the tear film, so there is no obstruction at all, or there is no drainage pathway lesion, or it could be a lacrimal pump failure, like for patients who have facial palsy, and then the Horner muscle and the lacrimal muscles are not efficient, are not contracting, so they are not creating the positive pressure to push the fluid. They are not creating the pressure to push the fluid into the nose, so that we have been able to bypass this this effect of the lacrimal pump failure by the injecting pressure of the cannula. So in order to differentiate between three different options here, we do what's called the Jones-Dye test. The Jones-Dye test is a test to do for cases of partial obstruction, or for cases of in case of there is a hard stop and the saline passed to the nose. But if there is no saline passed to the nose, then the test has no value. So to summarize, if there is if we have a soft stop, then if we inject and the fluid comes from the inferior canaliculus, then this is a lower canalicular obstruction. If we inject and have a soft stop and we inject and the fluid comes from the upper canaliculus, then this is a common canalicular obstruction. If we inject and we have a hard stop and we inject and we find that the fluid coming from the upper canaliculus and there is no fluid coming from the nose, this is a complete nasolacrimal duct obstruction. But if we inject and we have fluid come from the nose, then it could be either partial obstruction, such as stenosis, or lacrimal pump failure. Hold on, please. If we inject through the inferior canaliculus and the fluid is retrieved from the nose, it could be either partial stenosis or it could be a primary hypersecretion, or it could be due to lacrimal pump failure. So in order to differentiate between these three options, we do what's called the Jones dye test. So the Jones dye test, we do it in case of partial obstruction or in case of that there is a passage of tear of the lacrimal fluid or the saline through the nose after there is hard stop. But it is not done in case of complete obstruction. As if we have complete obstruction, then case is closed. This is a complete nasorectal duct obstruction. The Jones dye test itself is not done frequently in the clinical practice, but it is for some reason present in the books. So it will be the primary Jones dye test and the secondary Jones dye test. The primary Jones dye test will differentiate between two of the three, which will be the partial obstruction from the hypersecretion of tears. This can be done simply by putting a fluorescein drop into the conjunctival sac, and then after 5 minutes we will check if there is any fluorescein retrieved from the nose by using a cotton tip. So we put a cotton bud in the inferior turbinate at the nasorectal duct obstruction. If it is positive, so that there is a dye coming from the nose, this means that there is a patent lacrimal system and the watering was due to hypersecretion. But if it is negative, then there is no dyes coming from the nose. This could be either a lacrimal pump failure or a partial obstruction. So in this condition, we do the secondary Jones dye test in order to differentiate between the lacrimal pump failure or partial obstruction. So here is what's called the primary Jones dye test. We put a fluorescein strip into the conjunctival sac so that we stain the tear film into the conjunctival sac, and then wait for 5 minutes and put a cotton tip under the inferior turbinate. If we find that there is a fluorescein stained fluid coming from the inferior turbinate, and there is a fluorescein staining here, this is positive test or positive primary Jones dye test. This means that there is a primary hypersecretion. But if there is no fluorescein retrieved or no fluorescein stained fluid is retrieved from the nose, then this means that either there is a stenosis or a partial obstruction and the fluid is trapped within the canaliculi and the sac, or there is a lacrimal pump failure. So the lacrimal fluid may not enter the lacrimal system from itself, from the first place, or the nasorectal sac, and the nasorectal duct doesn't have any stained fluid. And there is a lacrimal pump failure due to a paralysis of the orbicularis oculi muscle. So what will we do? We do the secondary Jones dye test. In the secondary Jones dye test, it will differentiate between the partial obstruction and the lacrimal pump failure. And in this test, we irrigate the lacrimal system using a saline stent with fluorescein, so that we push the saline stent with fluorescein under pressure. And again, we put the cotton tip under the inferior turbinate. If it is positive, meaning that there is a dye coming from the nose, so this is a partial obstruction. But if it is negative, so this means that there is no dye coming from the nose, or the fluid is coming clear with no dye didn't enter the lacrimal system. So this means that this is a lacrimal pump failure. So here we inject the saline, and then we observe if there is a positive result. If there is the saline stent with fluorescein is retrieved from the nose, this means that there is a partial obstruction, and we have been able to overcome this obstruction by the pressure force of the injection. But if it is negative, so that the fluid is not stained with fluorescein, this means that the fluorescein didn't enter the lacrimal sac in the first place. So this could be this could be due to partial obstruction, or sorry, this could be due to lacrimal pump failure, or that there is a paralysis of the orbicularis oculi, so that it didn't create a negative pressure to suck the fluorescein from the conjunctival sac. So to summarize, the process of probing and irrigation. After dilatation of the punctum, we put the cannula, and then we will do irrigation. So sometimes we can do the irrigation using, you can do the irrigation through the same cannula, or that we can do the probing and the irrigation in the same step. So we can put the cannula as a probe, and then we inject. So we can find either a soft stop or a hard stop. So a soft stop means that the obstruction is present either the common canaliculus or in the lower canaliculus. But the hard stop means that the cannula entered within the lacrimal sac. So here we have three options. It could be either partial obstruction or primary hypersecretion or the lacrimal pump failure. The primary Jones dye test one will differentiate between the primary hypersecretion or if it is not primary hypersecretion. So if it is positive, then it is a primary hypersecretion. If it is negative, then it could be either lacrimal pump failure or partial obstruction. And in this case, we differentiate between both of them by the secondary Jones dye test. So if we inject the fluid and then we retrieve a fluorescein stained saline, then this is a positive test and positive secondary Jones test. So this means that this patient has a partial stenosis or partial obstruction. But if there is no, or the fluid retrieved from the nose is not stained, so it's called negative, and this patient has a lacrimal pump failure. So as I told you, this test is not usually done in the clinical practice, but we do an imaging techniques in order to detect what is the site of obstruction. So the first one will be called the contrast dye dicrocystography. In contrast dye dicrocystography, we inject a radio-opaque material called the lipidol. This lipidol is injected into the canaliculi, and we take a magnified images in order to see if there is any site of obstruction, if there is any presence of diverticuli or fistulae or filling defect or masses. And so this test can interpret what is the anatomical location of the obstruction. And if there is a normal dacrocystogram and the patient is complaining from the epiphora, then we can suspect a pump failure. Or anatomical obstruction, for example, for any problems with the nose. So here we can see that by injection of the dacrocystogram or the injection of lipidol on the right side, you can see that the lipidol has passed through the lacrimal system and passed through the nose, while in case of the other eye, there is complete nasolacrimal duct obstruction. In the left eye, the sac will be distended and there will be complete obstruction, and there is even pooling of the dye coming from the upper canaliculus and lower canaliculus. So this is what is meant by the dacrocystogram. The other method is called the nuclear lacrimal scintigraphy, which is the same like dacrocystogram, but instead of using a radio-opaque material, we use a radioactive material. This radioactive material is called technetium-99, which is delivered to the conjunctival sac and imaged by gamma camera. It doesn't provide a detailed anatomical visualization, but it is very sensitive in case of incomplete block, especially for the upper lacrimal system. So if we have an obstruction for the upper lacrimal system, we may consider nuclear lacrimal scintigraphy over the dacrocystography. Here is the image of the dacrocystography, sorry, the lacrimal scintigraphy. And this will be the end of the first lecture. So do you have any question in the lacrimal system? Okay, so we'll take a break now for about 15 minutes. The second lecture will be the aqueous and intraocular pressure. So this will be after 15 minutes from now. Thank you very much for your attention and see you in 15 minutes.